2 sessions in this round of training. That means that we'll all be together this afternoon from 1 to 3, and then next week, next Friday, again from 1 to 3. So we are going to come together as a group for the very first time because I'm going to need you guys to do something with me. It is something I ask every audience to do, and that is simply because I really need your support. So I'm just going to be right out front and ask for your help. I would like everyone to take a quiet moment and send up some good vibes or prayers or whatever it is for you, because I'm about to try to share my screen, which is a really simple thing to do, but technology and I do not always get along. So fingers crossed. Everybody send me some good thoughts. I'm going to now try to share my screen and we will see how it goes. Dungarvin. Okay, so I'm going to close that and I'm going to open this and hopefully I will be able to do this so you guys can see the slideshow. So can I just get one little thumbs up or something from somebody to let me know that you guys can see it? I'm going to close that. And I'm going to close that and I need to get out of this. There we go. Okay, I think we are good. So, I'm closing this and we're going to get into it. Yay. All right. And hopefully you guys don't have to worry about that either. So let me move this out of the way. This is the project. We don't really need to worry about this. This is what Kevin and I are going to be involved with. And I want to start with these quotes. I really love these. I like starting things with quotes. I actually talk about that in my book just because I feel like, I don't know, other people have said things in a way that makes it kind of interesting. And I also think this is really important for setting the tone for how we're going to be talking about trauma today. So let's get into the quotes a little bit. And as I said, my background is from mental health. So I came to this work when I got to work at the state. I was a liaison between the Department of Mental Health and the Department of Developmental Disabilities. So I learned trauma for people. I did not learn trauma for folks with developmental disabilities as if it's some like special category. I think we all have much more in common than we are different. And so as we talk about trauma, this really lays out for you how I think about trauma, okay, and how we'll move forward together. So the first one I want to explain a little bit, this is actually from the dual diagnosis world. Tamsin Cottis is an English psychotherapist, and she ran a clinic in London, England, that only served people with developmental disabilities and mental health issues, which is pretty amazing. Imagine you could go to a full mental health clinic in, I don't know, Cleveland or Dayton or Cincinnati or wherever, that only worked with this population. That would be amazing. But this is what she had to say about the relationship between mental illness and trauma and developmental disabilities for their patients. She wrote, "It is worth noting at this point that many patients referred to her clinic seem to have become disabled more by their traumatic life experience than by any congenital impairment." Now, I want to pause here for a second and really let us take that in. What she's saying is that in terms of the day-to-day struggles that their patients had, trauma was a bigger issue than having Down syndrome or being on the autism spectrum or having Fragile X or whatever it is. And imagine if, let's for example, just take Ohio. Imagine if in Ohio, the way the laws were written were that when an agency like Dungarvin started doing planning, let's say I'm a new client for you guys, that the first thing you start with is not my congenital condition, not my syndrome, not my IQ, not any of that stuff. The first thing you start with is my trauma history, if that's known. What makes me feel safe? What doesn't make me feel safe? Right now, we do a better including those things, but they still are sort of add-ons. They are the beginning and the center of what we're doing. And obviously, I'm not saying that other information isn't important. Of course it is. But imagine that the first things you're learning about my trauma, that would really shake up how we start from the very beginnings of supporting and staffing some of our folks. So I think that's pretty incredible. The next quote is a name that some of you guys might be familiar with. Any of you who have a trauma background, or if you have had further training in trauma, or you've studied it, or you're just interested in it, the name may well be familiar. It, the best known name in the world today for any population about trauma. And in fact, when I taught trauma at the MSW program at Ohio State, I used his most recent book as one of our prime textbooks that we used for the course. His book is The Body Keeps the Score. I also, as a trauma therapist in private practice, will often recommend that my patients read it so that they can have a good grounding with me as we work on their trauma together. So I got to see him in a training, and this is what he said. In fact, the past is the past, and the only thing that matters is what happens right now. And what is trauma is the residue that a past event leaves in your own sensory experiences in your body. And it's not that event out there that becomes intolerable, but the physical sensations with which you live that become intolerable. And you will do anything to make them go away. Now, this is a short paragraph, but there's a lot happening here, and we're going to take a few minutes and break it down a little. I think is really, really important, because as the person in the individual's life that you serve, you, whether you're a direct service professional or a manager or a supervisor, if I have any SSAs or clinicians or whatever your role is, you may be the person who is helping the rest of the world to understand what is going on with this individual. Okay, so if you're talking with parents or family members, if you're foster parents, talking with an agency, if you are talking with an employer or another person on someone's team, whatever, you guys get it. You may be the person to help folks understand that trauma isn't then, trauma is now. I'll give you an example of why this is so important. I was presenting to a live audience, this was years ago, and an individual with a lot of letters behind their name, we'll just say that, raised their hand and said, I meet, I think weekly or monthly with this person, with this individual, and my individual experienced a sexual assault about 30 years ago, and they want to talk about it every time we have a session. When will they stop talking about it? Well, so, the issue there is not, well, it happened 30 years ago, you need to let go of it. The issue is whatever that residue of trauma was for that person, they are still dealing with it now. And if you yourself have worked with folks with trauma, or you have people in your family or loved ones, or you perhaps yourself have grappled with trauma, you know that sometimes well-meaning people will say, oh, well, you just need to let it go, or try not to think about it. And it's kind of like if you have trauma, you're like, oh, I should just try to not think about it. Great, what a great idea. I wish I thought of that. Believe me, everybody has tried that, right? It's not about just don't think about it. And that may sound really obvious and silly, but think about how many treatment plans or support plans for individuals with dual diagnosis have somewhere in them, whatever the language might be, redirect. Now, that's a big term that covers a lot of different things. I'm not saying that's always the point, but in some cases, I think when we have an individual who's experienced trauma, that's kind of what we're saying is redirect them, distract them, have them not think about it. And if trauma were in fact just a past event, maybe that would be great. The problem with trauma is not what happened in the past. The trauma is people are re-experiencing it or reliving it. It is still affecting what's happening today. That is the issue with trauma. So you may be the person who has that conversation and helps someone understand. And I'm not saying you all have to be trauma therapists or clinicians or anything, but simply being able to say, it's not about letting go. It's not about the past. It's about what they continue to experience now. That's a really, really important thing to be able to translate and help people understand. And is often the case with folks with developmental disabilities. It's not the person with the developmental disability that really has the issue in this case. It's the people around them who don't get it. And so your ability to be that ambassador or to be that translator makes you incredibly important in their healing. We'll talk more about that, but that's why I get so excited and so passionate about getting to talk to you guys. I love talking to trauma therapists. I love doing, more advanced trainings about very specific things. But really, when we talk about what is it that allows folks the opportunity to heal, it's the people who are in their lives the most. And that is often the direct service professionals, the managers, the supervisors, the foster parents. And that's why I am so excited to talk to you. Okay, so we'll come back to that, but let's move on. So what is trauma is the residue that a past event leaves in your own sensory experiences in your body. And it is not that event out there that becomes intolerable, but the physical sensations with which you live that become intolerable. The best way I can talk about this is to tell you a story from my life. It was not my experience, but this was a story told to me by one of my professors in college. And he, in fact, was really instrumental for the path I took, especially focusing on trauma. So my professor was a young man in the late 60s, and he grew up in rural Ohio. And like a lot of boys from rural America, he volunteered to serve his country, and he went to serve in Vietnam. So he did a tour of duty for a year. And his role was to be a medic. So the way that worked, for those of you who might be unfamiliar with it, is in that war, they would be at a medical base somewhere in country, and they would get a call over the radio that there was fighting, and they would jump into a helicopter and fly sometimes through thick, thick jungle canopy trees, which meant that there was a real risk that they could break a blade of the rotor off and everybody would crash and die. They would fly to where the fighting was. Hopefully there was no anti-aircraft fire. They would land, hopefully not on a landmine, blowing everyone up and killing everyone. They would jump out of the helicopter. They would rush to where the soldiers were. They would grab the soldiers to get them back onto the helicopter. And I will not describe to you the way my professor did what would sometimes happen when they would try to go to pull those bodies away. They would get the soldiers onto the helicopter. They would take off. They would fight to keep the soldiers alive long enough to get them to the medical base. And needless to say, many soldiers did not survive that flight. And I will also not describe to you what he said that was like, what he saw, what he heard, what he experienced on that flight back. That was his job every day for a year. And then he came home and he finished college and eventually became a therapist and a PhD professor. And he married a nice lady here in Columbus, Ohio. And then one day he and his wife decided to go to the movies. So the movie they went to go see is called The Deer Hunter. And it's an older movie now. Some of you may not be familiar with it, but it was one of the first very realistic, very graphic movies about the Vietnam War. And what he told generations of students that he taught is that he did not know what was on the screen when this happened because his brain did not record that information, so he didn't have access to it. But what he did know was that one minute he was a PhD social worker sitting next to his wife watching a movie. The next thing he knew, he was crouched in the middle of the movie theater aisle screaming, incoming, while his wife and an usher were physically dragging him out of the theater. Now, I'm going to assume that none of you guys knew my professor. He's passed away now. But you'll have to take my word for it when I tell you that he did not choose to do that. He did not decide to leap out of his chair and crouch in the aisle and scream while his wife had to drag him out of the theater. He did not choose to disrupt a theater full of strangers, humiliate himself, terrify his wife. That was not a decision that he made. Now, that might sound really obvious to you guys, right? Like, who would decide to do that? But I want us all to be honest with each other for a second, okay? And if we were all together in a room right now, I would ask some of you to tell me what would happen if instead of being a professor and a therapist, if he had been an individual with developmental disabilities and he was on an outing from a group home, or he was a teenager in a special ed classroom and they were at the movies, and that had happened. What would my professor have been told when they got back home or when they got back to the classroom? I think we all know the answer, right? He would be told, uh, that's the end of movies for you for a while. And why? If we were all in the same room, we could all say it together at the same time. Because of your poor choices or because of your behavior. And it's entirely possible that my professor would have been given a behavior plan as a result of this, right? And I get it. You know, if I don't know him and I'm just another person in the theater and that happens, I have no idea what's going on. It just looks bizarre to me. I understand how challenging this is. What also I think makes it hard is that when my professor was out of the movie theater and was sort of, coming back to himself, he very quickly was able to use his words again and reassure everybody and reassure his wife and say something about, what he thought had happened. Now imagine if language was never easy for him, or English was his second language, or he had no verbal language at all. How hard it would be for anyone around to understand what was happening. I get it. But we tend to assume that people are doing things on purpose. And we certainly would assume that this was a behavior or a choice. And my background in mental health is that if we're calling it a behavior, like I'm sipping my drink, I lift my cup and I sip through the straw, you assume that I decided to do that, right? It was a choice. If I were doing this training with you guys right now and I suddenly had a seizure and I collapsed to the floor and I was having a grand mal seizure right in front of you, none of you would think, that's an odd decision. I wonder why she chose to do that right now. You'd be very clear that this was out of my control. This was not a decision I was making. Um, as we look at trauma and when we look at what is actually going on in the brain and the body, and that's a lot of what we're going to be doing today, what we'll see is that what was happening in my professor's brain and body in that moment was much closer to a seizure than it was to a decision in terms of what parts of the brain were active and what parts of the brain, this is really important, are not active at that moment. He was not choosing to do that. And yet, if he has a developmental disability in our system, especially when we don't know someone's trauma history, and sometimes we can, and sometimes we just can't, which we'll talk about, we're likely to decide that they're doing that on purpose. And we'll call it something sometimes like oppositional defiant behavior or attention seeking or manipulation or whatever. And that's another way in which your willingness to do this work and your participating in this training is so important. And I'm so grateful to you because, again, you might be the person who helps others to not make that mistake or to not make that assumption and to look a little more deeply. And we'll talk more about that, but I want to finish up this quote. Like I said, there's a lot going on in this short paragraph. So the last thing van der Kolk talked about here, he said, the physical sensations with which you live that become intolerable, and you will do anything to make them go away. I want you to imagine just briefly, and I will not ask you to reflect on this for a long time. I absolutely will not ask you to share anything. But just for a second, if you can allow yourself to touch in with what level of terror or horror would it take to make you leap out of your seat and crouch in the aisle and scream? That level of terror or horror or fear, whatever you want to call it, is unbearable, right? So when van der Kolk said, you will do anything to make them go away, that's what he's saying. That level of terror and horror and fear and agitation is so awful, you will do anything to make it stop. And when I say anything, let me give you a short list of the things I personally would be willing to do to not experience that, especially as is the case for a lot of our folks, if I didn't know what would trigger it, if it could just happen at any time. Here's what I would be willing to do. I would be willing to overeat, binge, undereat, starve myself, um, bang my head, cut myself, drink myself into a stupor, use illicit drugs, sleep with inappropriate people, gamble, shoplift. I mean, be physically aggressive, you name it. If that was the only way that I knew to stop that, I would do it. And what's more is so would you. Any of us in the right set of circumstances, if we did not feel that we had any other way or didn't know any other way to make it stop, we would be willing to do any of that and more to make it stop. And I think of all the important things in this quote, and there's a lot going on, you know, as I said, there's a lot of important stuff. But for me, if I had to pick one word out of this paragraph, the word that I would pick that is the most important is the word you. And when Vanderkolk was talking to this audience of professional people there for a day of training, he looked right in the audience and he said, "You will do anything to make them go away." He did not say, if you're some messed up veteran or if you've got mental health problems or, if you have special need. He didn't say any of that. He said, "You will do anything to make them go away." And he meant you and me and him and anybody in the right set of circumstances. So as I started this training, I said, I very much believe that we are far more similar than we are different. And that is not to minimize the differences, to minimize the very individual and specific ways that our folks experience the world and the very specific ways in which they need support, the very specific things they need to thrive. I get it. I'm not saying we should erase that. I'm simply saying, as human beings, we are much more like each other than we are different from each other. And so I think that it's really important for many things, but certainly for trauma, when we think about how we understand and are present for and make space for trauma in the lives of our individuals, that we see that in the right set of circumstances, we might be in a very similar place. We might be willing to do very similar things. I'm hoping also, along with that kind of shared humanity, that it's kind of causing you to think through some folks you've worked with or some things you've seen people do, and maybe it's putting some things in a possible different light. Okay, I'm not saying that everything everybody does all the time is always about trauma, although in a little bit when we look at how widespread trauma is in this population, it's a pretty solid bet at any given time. But I do think it helps us to start adding that lens. Maybe what I'm seeing, maybe what this person is going through, maybe how the world is experiencing this person has something to do with trauma. And that is especially important when they're doing something that we find challenging or difficult or scary or dangerous or gross or weird, right? To have that lens in place. The last quote, compared to all these other things, it's the shortest, it's the simplest. In some ways, it's my favorite because it's so elegantly simple and so heartbreaking. Pierre Genet, just to let you know who he was a 19th century, so like 1800s, French neurologist at the very, very beginning of what we might think of as like modern brain science, okay? And kind of laid the foundation for a lot of what would come in the 20th and 21st century for how we understand the brain. And this is what he said about trauma. He said, "Trauma is a disease of not being able to be here." And that to me encapsulates really all the things that I've been saying about why I'm so grateful that you guys are doing this training. Imagine what would happen if I reacted the way my professor had reacted. And I'll give you guys an example. I'm going to use Anthony. Your name popped up, so I'm going to use you. Let's say that Anthony is my new staff person. Okay, he's my new DSP, and he's starting his first day of work with me, and he's, showing up bright and early, and he brought Timbits for everybody. I don't know. And whatever it is about Anthony, I can't see you, but let's say he wears glasses or he's got dark hair. I don't know what it is. But there's something, okay, that triggers me the way my professor was triggered in the movie theater. And I start screaming, or, well, let's make it really fun. Let's say that I just immediately punch him right in the face. right? What's going to happen right away? I am not going to be working with Anthony. And depending on what the situation is, I may just have lost my job placement or my group home or my ability to be in this classroom or whatever it is. And I'm not saying that I should be allowed to, just punch people, but is Anthony actually a threat to me? No, of course he's not. He brought Timbits. He's great. Anthony, I am reacting to something that isn't there. I am not in my environment appropriately. I'm not in my time and place. This is not what's going on. What I'm reacting to maybe happened miles and miles and decades away from me. But now I've lost this ability to interact with this person, or I've lost this setting. Trauma took it away from me because I can't be here and now. I'm still there and then, right? And as we'll see as we get further into the training, it may even have infiltrated every part of my personality, every part of how people see me, how I see myself, how I move through the world. Trauma took away my authentic self and my ability to be in my real life here and now. And this is what Jenna was talking about. And this is why, as we'll see over the next 2 weeks, you might be the best bet our individuals have to get to live their actual lives as their actual selves. And for that, I'm very grateful. So that was a long time on one slide, but I really wanted to lay that groundwork, as I said, about how I think about trauma, how I talk about trauma. And as you'll see, again, we will talk about some of the specifics occasionally about developmental disabilities, but it's not because we have any reason to think that someone with a developmental disability experiences terror or horror or safety or connection significantly differently. They may express it differently. They may understand it differently. Certainly we mess it up because we don't know what's going on with them and we sometimes fail to support them appropriately. But really, human beings are human beings. And that to me is very important. And some other stuff, but we'll get into it. Okay, like I said, I get all wrapped up and I need to get you guys through this. So I'm not going to spend a lot of time on definitions. I don't know that they're super helpful. We will touch in a little bit later about some of the symptom clusters for a PTSD diagnosis, just so you guys are familiar with it. But just so that we're clear, we're back with good old Bessel van der Kolk here. What is a trauma? Now, all trauma is stress, but not all stress becomes a trauma. So what is it that takes something from a stressful experience to a traumatic experience? And I'll give you guys an example. Imagine that I am driving to one of Dungarvin's sites, and I'm on 70 or something, and it's, maybe kind of out of the way a little bit. It's out in the country. And I skid off the road and I roll my car into a ditch. I'm not seriously injured. I was wearing my seatbelt, of course. But I've got to unbuckle myself and crawl out of the car. I might be shaken up. I might be kind of freaked out. Could I maybe experience trauma from that very stressful event? Sure, maybe. But you could also imagine that, maybe after some time to calm down, it might be okay. Now I want you to take that same thing. Okay, I've rolled my car. I'm not seriously injured, same level, right? I'm knocked around a little, but I'm physically okay. But this time I'm crushed into the car and I can't get out. Okay. And I can smell gasoline leaking. And I'm thinking that at any moment the car is going to burst into flames. And it's not a busy road. There's nobody around right away. So I spend hours trapped in my car thinking that I'm about to die a horrible death. Is that more likely to be a trauma? Yep, for a couple of reasons. Number one, it is obviously more life-threatening if I can't get away and I think that I'm about to, experience this fire, explosion, whatever. I'm physically trapped. I can't do anything about it. And I want you guys to ask yourselves, most of our individuals are not trapped into a crushed car as part of their trauma, but how many of the folks we work with can't significantly change something about their life? They can't just up and move whenever they feel like it. They can't just switch jobs whenever they feel like it. How many of them are in a sense trapped? And when I do trainings for agencies that work with higher levels of care, like at a developmental center, and I've worked with amazing people who do amazing stuff. This is not to say that we shouldn't have those higher levels of care for people, but keep in mind, they lock the door at night. you can't leave. Right? So when we start talking about trapped, I want you to start expanding your thoughts as you're thinking through the folks you've worked with or the settings that you've been in. Some things should start to be coming to mind with this, okay? So any experience that makes me feel like I might be about to be seriously hurt or I might die, or that I might be emotionally overwhelmed or annihilated by the level of stress. I want to explain that just for a second. In this story, instead of being an adult in a car, now I'm 4 years old and I'm in a household with a lot of emotional and physical violence. Now, no one is hurting me, okay? I am not being physically harmed. I'm not being touched in any bad way. Okay, this is not directed at me. It's among the adults. Let's say it's a violent, volatile relationship among the adults. But I'm hearing the yelling and the screaming and the throwing things and the police being called and all of that. I hear it at night when I'm in bed. Might that be emotionally annihilating and overwhelming for me and ultimately traumatizing for me? You betcha. So trauma doesn't have to be something that is physically threatening, although it absolutely can be. And it is something that, for something to be that sort of like, single event, what we'll later call a big T traumatizing event, it's not merely stressful, it overwhelms our ability to cope. My ability to unhook myself and crawl out of the car and use my phone and get a tow truck and be checked out and I'm physically okay. Those are coping skills that I can use that may help this not be a traumatizing event. So really think about not just the magnitude of the stress, but also what can I do for myself? What can I do to get out of it? Vanderkolk at the later part is talking about when I'm reacting with helplessness and paralysis, that might be physical. I literally can't get away, or it might be emotional or situational. I can't do anything to help myself. All right. So when we talk about a traumatizing event or a series of traumatizing event, these are the building blocks of it. Another way to think about it is simply something that makes us feel unsafe and out of control. All right. If it's just one of those two, it might not necessarily be traumatizing. When you've got those two things together, I am unsafe. I am afraid for my safety, emotionally, physically, whatever, and it's out of my control. There's nothing I can do about it. That's the recipe for trauma. And we will come back to that as we talk about how we respond to trauma. Okay, I've already talked about this. Being able to move seems to help this a little bit. I have so much to do and so little time with you guys, just like Willy Wonka. It occurs to me when I say that, that some of the stuff will move through quickly, but again, you will be getting more material about this. Okay, so when I use the example of, I think it was Anthony, and I don't know what it is, Anthony, I don't know, he's super tall or he's whatever, and it triggers me, or my professor being triggered by the movie about Vietnam, that makes sense to us, right? It's kind of like, oh yeah, I kind of get that, which is great to know. And obviously, let's say, again, Anthony, I'm going to give you glasses. You guys in working with me might say, you know what, until we figure things out a little bit, let's have Laura not work with dudes with glasses. Fair enough, good start, right? That's okay. The problem with, there are two problems with triggers. Number one, sometimes it kind of stops and starts there. And we never go deeper into understanding how to help me heal from my trauma, how to be present with my trauma, how to be responsive to my trauma. We just look to avoid triggers. The other problem is that is due to the nature of triggers themselves. So I'm going to talk briefly about this. What we'll learn in a little bit when we look at the brain is that your brain is it's like a computer program that teaches itself, right? And every time it learns something, it changes a little bit. The best example that I can give you is I want you to imagine the smoke detector in your kitchen, which hopefully you all have. I'm sure you've all had the experience of you were making a pizza in the oven or you were making toast or something and it burned a little bit and there's a little bit of smoke and the smoke detector goes off and you're like, oh, you've got to clear the smoke away and you've got to, take stuff out of the oven, whatever. Okay, that's just the smoke detector doing its job. It's a hassle, but you're glad it's doing it. When we learn about the structures of the brain, particularly a system that is called the amygdala, The amygdala in sort of an oversimplified shorthand is like the smoke detector of your brain, okay? It's constantly checking the environment to see if you're safe. Just like your kitchen smoke detector, I guess, is testing particles in the air. I don't really know. But it's testing something. So now imagine that every time that smoke detector goes off, it gets a little more sensitive for the next time. So the next time you're careful, you're like, I'm not going to burn the pizza this time. And you don't burn the pizza, you're just making the pizza. But the smoke detector goes off anyway. And you're like, you reset it. And then the next time you're just boiling hard boiled eggs. There's no smoke whatsoever. And it goes off again. And then the next time you're just running hot water in the sink. And then after that, it starts setting itself off. So nobody's in the kitchen. It's the middle of the night. You're in bed and the smoke detector goes off. The problem with trauma is the brain gets better at whatever we ask it to do a lot of, including its alarm systems. And so, what can happen for people with trauma, especially if you've got what I call the trifecta, the dark trifecta of severe trauma, early in life trauma, or chronic trauma that's repeated. And we'll talk more about this, but especially if you've got all three, and many of our folks do, then the brain becomes wired for that alarm reaction. And what that means is, and I experience this with my trauma clients all the time, sometimes we can identify a trigger and that's great, but sometimes you don't know what set it off. You might never find out what set it off. And there's an even bigger problem than that, which is, again, especially if trauma is repeated, severe, or started early in life. Let's say, for our purposes right now, we'll say childhood, but especially earlier childhood, like 0 to 7. It's like the wiring all through a building, not just in the kitchen. Okay. Or now let me switch metaphors for you a little bit so that we can make sense of this. Focusing on the traumatic event or things that trigger the traumatic event is understandable. Like my professor never went to any more movies about the war. Good plan, right? But trauma can get everywhere into someone's psyche. So the best analogy I have for this is imagine a ship on the ocean, okay? And there's a hole in the side of the ship. Now, at first, where does the water go in? It goes in where the hole is, obviously. But if nobody knows about it and nobody plugs that hole, what happens? Well, the water gets everywhere. The water seeps into everything. And eventually, it can fill the ship. Eventually, it can take a whole ship down just from that one hole. So trauma can be like that, especially early, especially chronic, especially severe. It can affect everything about you. And these next two slides really touch in on how trauma isn't simply, I can't be around dudes with glasses. Okay, it can be pervasive. So things about how aware you are of your thoughts, feelings, and sensations and where your body is. We'll talk more about that later, but when your body is a scary place because you have those scary reactions to things, people often are kind of cut off from their body. They don't feel their body very much. They're kind of numb. I've observed that a lot of my clients with serious trauma have trouble feeling their body. They don't always know when they're hungry, when they're full, when they're tired. They tend to bump into things a lot, literally. How you react, think, judge the intentions and actions of others, solve problems, get your needs met, and imagine your future. Yeah, that describes most of the teenagers I worked with, right? Now, some of that is also being a teenager, but I worked with a lot of kids who had incredibly short fuses. Someone bumps into them in the hall at school and they turn around swinging. You work with some of those people, right? Where everyone warns you, right? When you first come to this location or you're first working with somebody, they're like, oh, hey, don't come up behind Laura and put your hand on her shoulder because she'll turn around swinging long before she looks to see who you are. People who assume that other people who are out to get them will attack first and ask questions later. You can imagine all like just the constellation of how someone handles themselves and sees the world if they think if their body reacts in such a way that they're reacting like that, or the opposite, they shut down, they don't react at all, right? To something that obviously should be warning them that something is dangerous. How quickly and accurately you respond to your environment. We just talked about this. This next one, I'm just going to give a few quick examples because I never have as much time with you guys as I would like. But if I don't know if I have any medical folks, any nurses, any EMTs, anyone who ever worked in that world. But you guys know the toll that chronic stress takes on a body, right? When people can't relax enough to fall asleep, when people are gritting their teeth or rocking or pacing, or they've got chronic stomach issues or chronic high blood pressure, that can start to affect everything about our physical health. If we, occasionally being agitated or anxious, we can handle that as a body, but we're not meant to live there, right? We're not meant to be on high alert all the time. And some of our folks spend most of their time there. So the people, especially who have the mysterious tummy troubles that never seem to get worked out, or the mysterious headaches, or the mysterious body pain, again, when we can't easily see the cause, it's easy for us to write it off as attention seeking or malingering or whatever. And that sometimes might be the case, but again, think about how many folks you work with or you've supported, or if you're a supervisor, even some of the stuff your staff experience, where it's a reaction to their body constantly being tense. So you guys get the idea. Trauma isn't just about the triggering event. Trauma isn't just about the thing that triggers the previous trauma. It's seawater that can get everywhere in the ship. Same thing, la 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 la. I want to talk about this last one very briefly. How you see yourself and other people as valuable, worthy, and lovable. We know that a lot of people do not see other people, and especially do not see themselves as valuable, worthy, and lovable. Now, some of that has to do with the messaging that our culture gives anyone who's different in any way, especially if they have a visible disability, or if they are neurodivergent and it's not visible. That's its own other side of the coin, which can be challenging. But trauma absolutely can teach someone that they are not of value because they have not been treated as someone of value. So that makes sense, right? So this is why, as you are working with your folks and as Dungarvin is becoming more trauma responsive, if you know triggers, if you know my triggers, great, that's lovely. But don't get too hung up on, oh, we need to figure out what everybody's doing, because it can be a little bit of a dead end. Okay. Like we said, sometimes the brain will set itself off and we never know why. B, because trauma, when it's been early, pervasive, and severe, can just affect everything, right? Okay. We are going to talk a little bit about big T trauma, and then we'll probably come right up to our break, and we'll pick it up after that. So just around 2 o'clock or so. Okay. Now, big T trauma or capital T trauma, that's what trauma therapists, that's our shorthand for what could be a single life-altering event. Sometimes it's not one event, sometimes it happens over and over, but it's the kind of thing where it only has to happen once to mess things up for you. So this is a list of things where if I said I experienced this and I had trauma as a result of it, you'd be like, yeah, okay, I get that. So sexual assault, physical assault, verbal or emotional abuse, or exploitation, trafficking, war, a natural or man-made disaster, a traumatic loss, deprivation and powerlessness to act on my own behalf. I did some work pro bono with a refugee nonprofit here in Ohio, working with folks who had been political prisoners or who had been tortured. So things like that, imprisonment, stuff like that. Again, if I said I had experienced this, or, I survived a plane crash and I was experiencing trauma as a result of it, you'd be like, it would not confuse you. Okay. And when we look at, actually, I want to talk about this one more second. When we look at the rate of big T traumas, which could be a single event, that is life altering for someone, we already know, we start out knowing that people with a developmental disability are already at greater risk than the general population for having these things happen to them. And it makes sense, right? Because for some of these things, especially, they are more vulnerable. They are more easily exploited. People have easier access to do stuff to them, right? So we already know that the folks we serve have a higher level of major life trauma than the average person walking around, just statistically, okay? We're going to come back to that in a second, but to move on a little bit, as I said, not all traumatic events result in a lasting problem. Not all stress becomes trauma, although all trauma is stress. There are some factors that we know may play into something becoming traumatizing, and they're fairly common sense, right? Some of the situational factors are things like how intense was it? How long did it go on? Did it happen at daytime or nighttime? Nighttime is more traumatizing because we can't see what's going on. Did we have warning for it, which is similar? Was it preventable? Did someone do it on purpose? All of these things. Probably the most important thing is we know from study after study that the support system during and immediately after the traumatic event predicts whether something will become an ongoing issue with PTSD. So again, I simply point this out to say how many folks with a developmental disability have a robust and immediate support system during and after a traumatic event. Some of them, fortunately, do, but many do not. Many of them, in fact, experience trauma that nobody knows about. So of course they didn't have that. So these are just some of the factors that we know from research can influence or impact how traumatizing an event potentially can be. There's also individual factors, okay? So previous history of trauma, which we're going to talk about in a second. If you have a history or family history of any emotional disturbance or mental illness or any mental health diagnosis, we do know that there is probably a genetic component to resilience and vulnerability. And even within a family, you can get people with different versions of that gene. So some folks may have a little bit more resilience or a little bit more vulnerability. The thing I want to point out here, and this will actually be a good note for us to wrap up with, I want to point out previous history of trauma or stressors or abuse. And I talk about this at greater length in my book if this is something that is interesting or important to you. When we look at that, it kind of, again, makes sense, right? Like, yeah, if I've had trauma after trauma after trauma, this next one could be kind of the straw that broke the camel's back. There's only so much stress a human being can experience before it starts to be detrimental to us. But I have seen that understanding change depending on the person who experienced the traumas. I worked a lot with teenagers with a lot of things going on, including some teenagers who grew up with a lot of poverty, a lot of crime. I worked with kids who were in gangs, and I worked with teenagers of color. Now, obviously, not every teenager with color grew up like that. Some of them were in the suburbs. But what I saw was when you got that street kid, maybe that ganged up kid, whatever, people didn't look at that child and go, oh, this kid has had trauma after trauma after trauma. They are probably vulnerable to trauma. You know, if anything more stressful happens, what they say instead is, this is a street kid. This is a throwaway. This is a little budding criminal. This is, this is some hard kid, especially if the kid has a lot of, bravado and toughness, which you need to survive. And that led me to an experience that I'm going to share with you guys. And you can draw your own conclusions. I'm simply telling you both what my experience was as a professional and what study after study after study after study supports. And that is that how we diagnose things in people or how we assess things in people can be affected by how we see them. It's just true. So here's the story, and then I'll tell you the research. The story is I was contracted with a mental health provider to work on a backlog of cases they had. They had a clinical director who had left. They needed someone to read the case files, read the histories, the diagnoses, and then sign off on the diagnosis that someone with a lower license had given. And they, for Medicaid, which I was happy to do. So I was contracted to come in. I would do a couple hours a week, just reading through files and then reading the diagnosis. And it was a decent cross section of kids. I'm going to say about 200 of them, and about half of them were males, were boys, upper teens, and most of them were boys of color, mostly Black, a few Hispanic, and a couple of other things, a couple like Asian Pacific Islander, but the boys of color were mostly Black. And when I read their histories, they read very similarly to a lot of the other kids. Disruption of placement early in life, or chaos in their family, abuse or addiction issues or mental health issues in the family, crime, poverty, a lot of stressors, basically little trauma factories. Okay, so about 100 of these kids. Guess how many of them were given a diagnosis of trauma? Here's the answer: 0. When I say none, I don't mean, oh, is a small number or lower than it should have been. I mean 0. Presentations and histories that I know, if it had been a different kid, probably would have been assessed differently. Trauma wasn't even a rule out. Now, I will say this was about 10 years ago now, a little more. So hopefully things have changed in our awareness of trauma. This was a mental health agency, mind you, okay, who should know better. Developmental disability is making big strides to catch up. 10 years ago, DD was much further behind mental health, but this agency should have known better. Not one kid. And what this is supported by in the literature, what study after study after study after study has told us, is that when you get a kid with similar presentation, doing similar things, saying similar things with a comparable history, that if it's a girl, that child is more likely to be given an emotional diagnosis: depression, anxiety, trauma. And trauma used to be categorized as an anxiety disorder. The most recent DSM, it's its own category, but it used to be categorized as anxiety. In other words, we tend to see girls as sad. Boys, teen, young, or, young to older adolescent boys, and this is true for any race, but boys generally are more likely to be given a behavioral diagnosis: ADHD, oppositional defiant disorder, which is a dumb diagnosis that I don't think exists, intermittent explosive disorder, whatever you want to call it, conduct disorder. Boys are more likely to be seen as bad. Girls are more likely to be seen as sad. Boys are more likely to be seen as bad. That's how you can remember that. And that goes up exponentially if it's a boy of color. Okay, so why am I going through all of this? Because most of you guys, I'm assuming, are not diagnosing people. I may have some clinicians in the group, but probably I don't, or I just have a couple. So why is this important for the rest of you guys to know? Because it's important to know that when you read a chart or you read a file or someone is telling you it's in someone's history, just because a human being with a lot of letters behind their name gave someone a diagnosis doesn't make it correct. It might be, right? I'm not saying that psychologists and psychiatrists and social workers, which is me, are always wrong. Certainly not. But we are human beings, and we can be affected by bias just like anybody else can. So you, again, may not be the person who's making that diagnosis, but knowing this, armed with this information, you might be the person, if you're like, trauma is not anywhere in this person's clinical record, but I think it could be a factor. Maybe we should have someone take a second look. Maybe we should look at this a little more closely. That's really important. And you might be, as the direct service person or the foster parent or the manager, the SA, whatever it is, you might be the person who is in that moment advocating that gets someone a better, more nuanced, more thoughtful, more appropriate assessment. So do not let someone's appearance or how the world maybe experiences them to throw you off. Okay, that is a good place to stop. So let me see what time it is. It is 2:05. Okay, we will come back at 2:15. I'm going to leave it here. I'm going to pause the share, and I'm going to try to pause the recording.